please give her a warm welcome. We'll pass over to Anne.
So I was asked recently, how much fun am I at cocktail parties? And I said, I have this really amazing ability to put people to sleep. I recently did a talk hosted by Patrick Moore down in Chicago for Disrupt HR. And within 5 minutes, I had people asleep. So in addition, I gave birth to a tiny human who actually turned out to be a medieval torture device who has been disrupting our sleep. So last night, he went to sleep about 9 o'clock, did not wake up until midnight. I thought, 3 hours of sleep together. This is amazing. It happened again from midnight, 12:30 to 3:30. I said, wow, I am going to come here so well rested. He did not go back to sleep after 3:30 this morning, so we will see. But as a new mom, I've also learned that there are incredible devices that you can use in your self-funded plan. There's actually a wearable that will go on a breast and measure how much the baby is getting. That's incredible. Well, why does that matter to you as self-funded plans? Babies who are not getting enough food and moms who are struggling to breastfeed are incredibly expensive. Very, very expensive. They go to the ER, they have hospital admissions, they have to have fluids, all of these things. So, fun fact, infant is the name of the thing. I do not rep them, I do not get money from them, but it's something to start thinking about as we have the conversation about reducing risk and how we're framing, what are we financing, what are we picking for our benefits. So now you can go to sleep. I have used AI in some of these slides. I did this slide deck approximately 2 weeks postpartum. There is an ostrich with 3 legs. The rest of it is my IP. So, first message, how many of you all are brokers in here or advisors of some variety? Okay, so there's a few of you. First message is, guys, don't be a dino. I'm gonna compare sort of the change that is coming to a wave of challenges that I saw when I was working in real estate. It was my first job out of college. I had said no way to healthcare, and it was 2006. Well, as 2007 came along, my broker at that point had 7 people working for her. I was there. I was on a path to become a real estate agent. Guess what happened? Well, the real estate collapse started. And she had Wells Fargo come to her. She was a boutique firm, always had the most beautiful houses, great, great woman. They said, do you want to do repossessions? And she looked at me and said, oh, no. Well, it's funny because a few years later, we caught up when I was getting married. And she said to me, Anne, I'm so grateful you got me on that platform because without it, I wouldn't have survived the crash. And so as you as a broker are thinking about how are you going to do your business, we're gonna do a little bit of stage setting. So you're all familiar with ERISA, which is the Employee Income Retirement Security Act that covers both your 401k plan and your health plan, otherwise known as a welfare plan. And really, anything that you're doing to protect your 401k plan really should be easily paralleled into your health plan. So if you're doing RFPs, talking with your vendors about fiduciary stuff, all of that translates really simply into your health plan. So what's happening now? Well, the lawsuits have started. How many of you heard about the lawsuits in the 401k space in the early 2000s? Yeah, no, maybe? Okay, a few of you. Well, they've started in the healthcare space too. There's a few, including mine, that are outstanding. And more interestingly, you'll see as I proceed with the conversation that there are more and more lawsuits from plan sponsors, that is you all, against your vendors. Now that's a slight change, but if you're a broker and you're advising plan sponsors here, you probably don't want your plan sponsor to have to sue one of the vendors, right? And so what really changed was the Consolidated Appropriations Act 2021. You all have heard about this. It's nothing new. Really what it tried to do was equalize the reporting requirements and disclosures between the 401k space and, of course, the health plan space, which was not required at that point. And there's some fun stuff like your RxDC reporting. Make sure that gets done. Look at it. We'll talk about that in a minute. And also, the thing on Capitol Hill at that point was people are getting frustrated with our healthcare system. You'll hear Preston Alexander right after me talk about the accelerating hospital trend, all of these things that, quite frankly, Washington has created. And now they're trying to deal with the beast. But we'll save that for another time. But really, they expect you as employers now to start managing that spend, to start accelerating the change in healthcare that is needed. So as we're sort of paralleling this 401k space, I've gotten connected with a national RFP firm. So brokers, again, as we're talking, this firm is working with very large groups, 75,000, 50,000 lives. And one of the questions that they ask is, are you a fiduciary? Do you want to be a co-fiduciary? If not now, when? And what's interesting is that the answer is not now, but soon, within a year, 2 years. That's going to be a radical change for you, right? And so as we start measuring plan design, measuring advisor performance is actually a really great place to start measuring plan performance. Now, this isn't that you're mean or nasty. It's that, hey, let's be collaborative partners, that trusted. And so as we start to have this conversation, it's time to reframe your health plan. So let's talk about what the frame is. It's financing healthcare. It's identifying real-world performance. It's making sure it's accountable, and that you're measuring for employee-focused plans. And we'll talk about that in a minute. So the reality is, and you've heard it over and over here, you just heard it in the stop-loss thing, you're financing healthcare. How you choose to do that is you could go fully insured, or you can go self-insured. But if you're going self-insured, you are paying all these claims. Ultimately, you are no longer purchasing an insurance product. You are using vendors as a vehicle to pay providers. That's all. So really, what you want to start to understand, whether you're currently self-insured or you're looking at becoming self-insured, is how do you want to finance? Do you want to offload that risk entirely and hope that your BUCA or whatever is going to play nice with you and not understand what your data is telling you, all these other parts? Okay, go fully funded. But then you want to understand, who are you paying? What are you paying for? What are their incentives, right? Like, are there some things on the back end? And we'll talk about that in just a minute. Are you offloading risk? You heard about that in the stop loss. How are you managing that risk? And then ultimately, you want to ask the question, why did you hire this vendor? What is their purpose? And is it helping you achieve your financial measures and success that you want as a company? And of course, you need compliance with HIPAA, GINA, Consolidated Appropriations Act, MAPIA, all of these things. And you heard it before, you absolutely want a HIPAA officer if you're self-insured so that you can start to look at the claims. So, that didn't come out quite right, but let's talk about one of the most common contracts that we see, AWP plus or minus 22.5 across all pharmaceuticals. Well, guys, if we're becoming healthcare financiers, we need to understand AWP simply stands for ain't what's paid. Nobody's paying that, and you need to get a little more sophisticated. Additionally, we need to understand when we're chasing rebates, these are zero interest loans from your company, from your patients, to the biggest companies in the world. These are pharmaceutical companies, these are big insurance, these are 6 out of the 7 rank within the top 40 in the Fortune 500, and your company is loaning them money as you pay your invoices on day 0 to 30, and they refund you when they feel like it, day 90, 180, or more, potentially. So really thinking about how you're constructing your formulary. Are you chasing the rebate, giving that money away, letting it hit their revenue structure while you wait for them to reimburse you, or are you optimizing and looking for alternatives? That's when you start to really understand. So that gets us into, what is the real world performance of your plan? Are people able to access treatment? You heard about cash pay. Are they able to get into the doctor? We hear about waiting lists on mental health treatments because people are restricted in who they can access and where they can access healthcare. What's the current spend? Are you spending extreme amounts of money on ineffective care? For example, I'm working with a firefighters union down in Florida. Their plan, it's a national BUCA plan, Blue Cross Blue Shield, United or Cigna, I won't say which one. It's a government plan, and they have access to a center of excellence that caters to firefighters to help them with PTSD and substance abuse issues, because these are intertwined. They have a very high success rate. It's 90% success with no relapse at 9 months. That's fantastic. The comparators that they have access to on their current plan have about 10% success rate. So you're a plan sponsor. You have somebody going for inpatient treatment. This is about $20,000. And you have the choice between sending somebody to a place that has a 90% success rate at 9 months or a 10% success rate. What are you going to choose? What are you going to invest in? And so that really gets into, is the care provided adequate? Now, to understand these pieces, you want to get your data. You're going to hear this over and over again. You just heard it from our vendors. And I like to say, showing up at renewal, at these conversations, at these negotiations, as you heard from Dr. Smith here, is you're showing up in a one-horse buggy, and your TPA, your stop loss, and your PBM, they're showing up in hypercars. Not only are they looking at their own data, it's possible they're purchasing data from other sources, whether it's Milliman, actuaries. They could be potentially purchasing it from hospitals that are tracking what your people are landing on and searching for, because that's allowed. And so if you don't have your data, if you're not looking at it, if you're not understanding it, you're in this one-horse buggy. You probably haven't even crossed the start line when your TPA and your stop loss and your PBM are already hitting the end, right? That's a 3-second march. So let's talk about MAPIA. What is MAPIA? It's the Mental Health Parity and Addiction Equity Act. This is a federal law that even if you're not an ERISA plan, so if you're a government plan that falls under state, you are still actually required to follow MAPIA. There was an update with the 2021 Consolidated Appropriations Act. I know you're going to fall asleep. That's okay. But essentially, this is really getting into what are the non-qualitative treatment limits that impact access to mental health. So this could be things like a requirement for a care plan for mental health providers that does not translate over to physical health. It's a great example. One big warning, most major plans are not MAPIA compliant. So, as you're purchasing these things, and you're purchasing from a large carrier, you are potentially getting into a situation where you are purchasing a non-compliant plan. That's a problem. So, it's not a benefits mandate. Eric, the ERISA committee, actually took HHS to court, and the courts did say the rules that were promulgated last year by the Department of Labor were too aggressive and actually equated to a benefits mandate. But here's why I think it's still really important to think about non-quantitative treatment limits, You still have a requirement to provide a report upon request from a beneficiary. That's part of the law. That was not part of the rulemaking process. And B, you're purchasing something with your money, with your people's money, and making sure that they have access to mental health providers is simply good business. If people are showing up at work depressed or anxious, are they at their best? Are they going to give you 100%? Probably not. If they're struggling through addiction, probably also not doing very well. And so it's really critical to understanding what you're purchasing. When I was going through my MLS class, I asked one of my law professors who had worked at one of the BUCAs, Blue Cross Blue Shield, United, Cigna, Aetna, and I said, okay, so we know most of these plans are not compliant, whether it's with NQTLs there in yellow, non-compliant with the comparative analysis, which is 32%, and quantitative treatment limits, which are things like limiting the number of times you can go to a psychiatrist or a psychologist and not doing similar things on the physical health side. And she said, and I said, okay, so you've signed a contract, right? This is a contract law case. And she was like, and I said, okay, so you've signed a contract, you're in it, what do you do? Because that's the question, what do you do? She said, well, you can't extra legally contract. So if you've got a problem with the contract, with it not being compliant, you can actually start to negotiate around it. So again, this is where data becomes important. And it also drives accountability. So as you get transparency and understanding of what's happening in your plan, and you get your data, not only do you get a fabulous three-legged ostrich with its head in the sand, you start to understand and avoid situations that the trustees of the International Union Operating Engineers Local 49 Health and Welfare Fund, that is a mouthful, versus United Health Group. Why do we care about this case? Well, how many of you have ever violated your plan documents? Had paid for something that maybe was carved out? Nobody, right? Nobody does this. Well, except when you're United Healthcare. So in this case, and this is an alleged case, United Healthcare Group has been paying for GLP-1s using the Engineers Local $49, even though their plan document says we're only going to pay for a cheap generic for weight loss. Everything else is prohibited. This is to the tune of $3 million. They are now having to sue. Why is your data so important? Why is your RxDC report so important? The local engineers were waiting and relying on United Healthcare to provide them with an annual report of spending. And United Healthcare has not provided that in a couple of years. So they got the report and they saw GLP-1s. The allegation is that we're now in 2025. This goes back to 2019. 6 years, $3 million. This is not a joke. That's a lot of money. So get your data, know what's being spent. Do not rely on an annual report from the person managing your claims. So we at Equitable Evidence offer services, right? So we offer the ability to start to watch your plan's trend, understand what is driving your cost, and even what is the variance. So actually in red and you see this plan is actually overspending, and this is live data, overspending by $2.5 million in January of 2024. Do you think they knew that real time? Do you think that they could start to implement changes and strategies to address that? No. They did not hire us until this year. So they have overspent by millions of dollars. And if this is you, how do you go to your CFO or CEO or to your employees and say, sorry guys, we didn't see the trend until too late. We've got to increase your premiums or we've got to cut benefits. Then We also start to see, what are the top 3 drugs? Well, 2 of them are GLP-1s. A third GLP-1 is not too far below. The number 1 driver of this plan's prescription drug costs at 25% are weight loss drugs. That's really painful for them. And so thinking about how are we going to manage that? Do we need to bring in another solution? Do we need to think about how we're engaging with our membership? That's really problematic. But you want to know this so that you don't show up to your stop loss renewal realizing they've now lasered out all GLP-1s, and maybe, meaning they're not going to cover them because you hit that limit. Maybe that's a blessing, maybe it's a curse, but you've now got to figure out at renewal time, rather than ahead of time, how you're going to manage that. So I like people to be very prepared. I don't like surprises. And that's why I think walking into renewal with a knowledge and understanding of how that conversation is going to go is absolutely critical for your empowerment. So let's talk about another fun case. So Tiara Yachts versus Blue Cross Blue Shield of Michigan. Anybody heard of this case? Okay, yeah, there's a couple of you. All right, so again, hiring the right hand to do something that the left hand might also do is problematic. So Tiara Yachts is a yacht maker up in Michigan, and they are talking through what's happening. And please feel free to send in questions as we're going through. I realize you may not be familiar, and what makes sense in my mind, being awake since 3:30 this morning, may not make sense in yours. So Tiara Yachts, yacht maker, like any of us, right? Small business, hires Blue Cross Blue Shield, they're managing their claims. So they think everything is happy. Blue Cross Blue Shield is paying the claims, things are good. But they start to notice some irregularities. Well, irregularities are never fun in accounting. Anybody love irregularities that pop up in accounting? So Blue Cross Blue Shield was paying out-of-network providers at in-network rates, and then flipping it, and with what is called inductive flip logic, flipping them to out-of-network and paying them less. But here's the thing. They participated in a shared savings program. How many of you participate or know what a shared savings program is? Yes, most of you. Okay, this is great. This is really, really important stuff to talk about. So, shared savings program, of course, in this case, it's Blue Cross Blue Shield, so the person paying the claim is also the person identifying that, oh, oops, there was, or allegedly, very important to add allegedly, oops, we have a problem, or oops, we did it again, in the words of Britney Spears, that we keep paying these people in-network rates, they should be lower, but hey, we're getting 30% of this. That's really great. If you've ever listened to the Trade-Offs podcast with Chris Deacon on the New Jersey PBM side, you'll hear that this is not exclusive to Blue Cross Blue Shield of Michigan. Shared savings programs are very frequent. Well, there's a couple of pieces that are very interesting with Tiara Yachts. Initially, the Sixth Circuit found that Tiara Yachts did not have a case. It went up on appeal. And the Court of Appeals actually found that Tiara Yachts did have a case, that Blue Cross Blue Shield was, in fact, a functional fiduciary, and that there is the potential for prohibited transactions with Blue Cross Blue Shield acting as the recovery agent. Now, how many of you want to find yourself in a situation with a vendor who is creating prohibited transactions for your 401k space? Anybody? Yeah, no, not a fun situation. You don't want it on your health plan either. But unfortunately, what this demonstrates is that it's really easy to find yourself in potential prohibited transaction territory, but here's the problem. You probably don't know it yet because it's not been well litigated, and the Department of Labor is not really great at giving you guidance. So you really want a strong ERISA attorney if you're looking at these contracts because I don't want you to find yourself in these situations. So, US Beacon and others, I use US Beacon simply because Kimberly Carlson is a friend of mine, but these are pretty small, so I'm gonna walk you through some of the accounting and recovery that can happen, not just because somebody's getting paid in or out of network, but for example, in the upper left-hand corner, this is a $134,235 claim. They found $76,000 and some change in ineligible amounts. This could be unbundling, so typically in claims, if you have a service like a total knee replacement, you can't start charging for all of the stuff that comes around it, like the hardware and the screws and the this and the that. So if that happens, it's called unbundling, and those are ineligible charges. So the bill went from $134,000 to $58,000, essentially, and some change. So again, they found another group, and it was $296,000 and some change. They found $127,000 in ineligible charges. So when you're looking at your vendors to not only review for in and out of network status, you probably want somebody also looking at how well are these claims being paid. Another really great example that I didn't get in time to provide these slides, it gets to this concept of how are we paying, how are we financing? And Kimberly sent me a charge that was $8,200. And because of the network rate, it was inflated to over $100,000. Yeah, that's a problem. Why is that a problem? Well, I mean, it's 10 times the cost. And as now sophisticated healthcare financiers, you don't want to end up with a 10 times cost charge. But how many of you is that hitting also your stop loss coverage? And now you're incurring a claim when you probably didn't have to if you had just paid the amount done. All right, so measurement, you will find things to start working on as you get into compliance, as you start looking at, what is access, what are things going? And really, a lot of people, compliance is boring, but ultimately what you're doing is you're mitigating risk. And that risk reduction is really important, whether it's financing appropriately or looking at other stuff. And so finally, in my last few minutes, we're gonna talk about why employee focused and why this is so important. Well, as you know from your 401k experience, you're taking people's money, usually. If anybody doesn't take money from their employees for their premium, you can probably ignore this whole point. And God bless you for that, and we should talk afterwards. But essentially, as you're collecting this money, right, you are collecting and putting it into trust. And so you are taking this money and you need to act in their interest. And so that creates this fiduciary duty to act on the interests of the participants. And so 9 times out of 10, I'm gonna be really honest with you, this aligns ideally with the plan's interest, right? Who wants to go and pay more for anything when they don't have to? I'll tell you, it's so infuriating when I look now on a different plan and I say, if I had just paid cash for this, and I have these conversations very frequently with my doctors, if I pay cash, what's the cost? Okay, I'm gonna pay it up front. Maybe I seek reimbursement, maybe I don't. But it's incredibly aggravating when that happens. So maybe I'm a little bit sophisticated, but I do believe you can activate each one of your employees to be that same customer. And the other thing is, you want to document to a certain extent and with the advice of your lawyer. I'm not a lawyer, so I don't provide that advice, but make sure that there's process, right? So whether it's an RFP, and that's actually a pretty fun experience. Hire somebody, have them come in, do it yourself, ask the questions, demonstrate that there's a process that's looking out for the participant interest, and then you're probably gonna be in very good shape. So thank you guys so much. You've been an awesome audience, and I'm gonna take questions now.
So there are a lot of self-funded employers
Yep.
out here, some with us, some not with Self-Fund Health. And I think the trap we can fall into with the data is that, okay, we've changed our behavior, we're self-funded,
Yep.
and now we can see everything,
Yep.
potentially. Sometimes that's still, some guesswork.
Have a HIPAA officer, folks.
Yep. But I mean, even just seeing like, is this actually what we paid? Was this
Yep.
the allowed amount? Was this the claim amount? There's a lot of terminology.
Yep.
But I think the best performing groups that at least we have are the ones that Jonathan referenced, where they are looking at their banking, they're looking at their claims, and they're just looking and saying, what was this for? What is
Yep.
this for? What about this? Why was this so much? That's a strange, how does this ICD-10 code, contribute to this? And they're just asking questions, and they're educating themselves so that they understand, the flow of things. And you would be shocked how many employers come to us after they start with us, and they're like, I had no idea that that's what blank cost,
Yep.
or that's what this costed. But you got them to go over here. And so we see the delta now because we show on every monthly savings report, the clients here are going to know what we're talking about. They see exactly where the savings is coming from, because that is extremely important so that there isn't this funny business going on. And so, extremely important stuff. And I'm going to get to the questions, but I don't think this stuff can be overstated enough. And we probably, people like me, I'll fall on the sword, say that this might be the quote boring stuff, but this is the stuff that the industry knows better than us.
Yeah.
And if we want to fight the industry, then we have to know it just as well, because the insurance companies know this stuff through and through. They know what they're doing, right? And so if we want to win, we have to learn it just as well.
Well, and here's the other thing is never underestimate the power of a very uncomfortable question. And you may feel really stupid for asking it, but there are no stupid questions. My first degree was in rhetoric, and that's basically just a degree in figuring out how to ask the right question. And really, you would be surprised how much you can learn from somebody who is not able to answer a very direct question that makes a lot of sense to you, like, why does this cost so much here when over here it's so much less? Well, I've seen people struggle with that, whether it's a TPA or carrier, or even just somebody who is like, oh, don't worry about it, sit down and be quiet, because all you're doing is contributing to your maximum out of pocket. Well, okay, but still it's too much money. That's the point. And so I think that's, never underestimate the power of a really great question.
Absolutely. Okay, this is a great question. I'm going to do a little bit of explaining here. So what if you're working with a vendor that has shared savings?
Yep.
So I think a little bit different from the slide you were talking about, but I think it does apply to our conversation. How should we be reviewing and holding that partner accountable for not inflating the savings? And this is great. I'll explain why this is great. Our current clients already know why this is great question for us to be talking about, which I absolutely think we should. But what is your answer first?
Yeah, so I think it's really, really important when you're signing on that contract to understand how are you calculating those savings. Are they realized savings? Are they actualized savings? Are they based on
aggregates?
Yeah,
are
aggregates.
Are estimates?
Are you avoiding trend? Is it the billed amount versus the allowable amount? Like, how are they coming up with this? And I think you probably engage in other shared savings activities in other areas of your business. Take that experience, take that negotiating experience, and apply it here to healthcare, right? This is not new. That's what I want to emphasize is financing and figuring out how to pay for things. You all are experts at this. You are business people, you know how to do that. So don't just turn off your brain when it comes to healthcare.
So I'm going to add something, right? Because as an advisor, right, when I was an advisor and I had my own firm, I was paid on shared savings, right? Hey, company, if you're here, if I can get you here, I take a %. And it was that, there's a little bit of gray area there, right? And so do I like the model, the incentive? Potentially. when it is detailed and agreed upon beforehand exactly where that is coming from, and you can outline it at the time that it comes. And on top of that, I believe it should be capped at a fair rate that all parties agreed to. So like an example of, so for people that don't know, so just examples of shared savings vendors. So there'll be a vendor that says, hey, we can take your drug spend, on this drug from this, and we'll pay this for the specialty drug, and then we'll pay, percent of savings. You might have $1 million drug, and you might not have a cap on the shared savings, and now you're a 100-person company, and you owe a vendor $250,000 because they helped you apply for a manufacturer's assistance program and get this drug for free now, right? Now, in our case, right, with Self-Fund Health, the nurses are going to help apply for the manufacturer's assistance program, get that drug off the plan, and we'll take a percent of savings, but it's capped at $35 per employee per month, the annualized equivalent of $35 per employee per month, which we feel is a good alignment with you, and an incentive for us to have a win-win-win, the same thing that you have. And so our whole business model is predicated on taking the risk of, if we don't show you practical, actual, detailed savings in your claims, we actually don't get paid. And so I like the alignment, but it absolutely has to be so thoroughly detailed and nuanced that any CFO could look at it and say, yeah, that makes sense. I'm happy to pay that share of savings, right?
And you also have to think, I come from a legal background, think defensively. If this came up in court, could you defend it? And I'll say, often with these prescription drugs shared savings programs, I've seen examples where, because the drug is so inflated through a PBM, there was a PBS special last Friday on a woman whose drug that could be prescribed and administered in a physician's office for $8,700. She was getting it through a home infusion service, and it was, I believe, $88,000 per infusion. Don't quote me on that because I would need to go back. But if you're paying on a shared savings on that $88,000, you're actually still paying more than it would cost to purchase the drug and administer it in a physician's office. I believe it's like $15,000 if you're paying 30%. Right. So that's where, double check, right? Some of these people are very good salespeople, and that's fine. I'm not a salesperson, so God bless those who are. But really double check, look under the hood, and then also start to look at, the whole problem. If you are identifying really expensive drugs, well, maybe you need to start repricing the entire PBM market, not just one or two, and seeking a more holistic solution, because that's going to drive down your trend more aggressively than simply trying to do this nickel and diming of, one person or two people off the plan.
Self-funding is maddening. The self-funded world is maddening because there are so many more ways to nickel and dime and pinch money from plan sponsors and from employees. And the basic gist is, first thing is review the contract. Yeah. Ask them for a contract. And if they're like, oh, and they they don't give you a contract, or the salesperson isn't like upfront with that, that's usually a red flag right there, right? And so get your lawyer to review a contract. Is it simple? Is it easy? Do they understand? They can usually see a lot of the pitfalls and avoid a lot of the issues just by reviewing that thing and seeing how fair that contract is. Before I worked at Self-Fund Health, I asked John, send me a copy of your BAA and your ASA. Yeah. And I'm dumb, but I'm not that dumb to go to work for an organization that is going to be, messing with things. As much as I like John, right? I had to make sure that on paper it looked the same, and I could confirm that when I spoke with him, right? And I saw that, okay, it's in our contract. We are not collecting money from any other source except for the employer that we're working with. It is in our contract. It's a 2-page contract. Very simple to, I can understand it. And, music major, right? So, all right. Can you talk about your lawsuit?
No. Sorry, no.
Yep. Well, so the question is, was that before or after you had worked in the industry? I could answer this, but yeah, quick answer on that.
Yeah, so I filed while I was still an employee of J&J.
Yeah. This is a question based on what we just said. Doesn't Self-Fund Health do shared savings? Yes. How is theirs different? It's because we are showing you the difference between what you were going to pay at the expensive hospital system and what we were able to steer for you to pay at the direct primary care with our nurse navigation interference, that's a bad word, proactivity and steerage for it. And we show you the delta between those two things so you actually know absolutely what it was going to be, not the allowed amount, but the actual, what the paid claim would have been, and then what the actual amount was that we paid for. So we have the same incentive as you. Lower cost, higher quality care, better access for you, for your members, and that's where our incentive is too. If you have any other questions about that, absolutely, please come talk to us after this. I'm happy to show you sample reports of this. I mean, there's plenty of employers that are with us here that we could refer you to talk to them, because I think it is an extremely important thing for you to understand and for us to be on the same page with, because it's a big deal. How your vendors are paid and how they're incentivized makes all the difference. I mean, that could be, you could solve the story of healthcare if you just align the incentives to what the patient and the plan sponsor actually needed and wanted, right?
Yeah, and we actually missed one of my personal favorites, which is a grid that helps you start to understand, and this is something that I've developed myself. It's a risk management tool. It starts to ask the questions like, are you getting all of these questions? Like, are people saying that they're a fiduciary? If not, are they willing to act as, is it in the contract that they're a functional fiduciary? Or are you going to have to be in the position of Tiara Yachts or the local engineers and having to take them to court, which is extremely expensive. And nobody wants that, right? Like, let's keep people out of court. That's a great goal. And I think, one of the things about Tiara Yachts that might be not as obvious. So in the case of Tiara Yachts, part of the problem with a prohibited transaction is that Tiara Yachts is not, Blue Cross Blue Shield is paying the claims, deciding to pay them, and then going and recovering that money. So it's the fact that it's doing both tasks, right? So inherently, shared savings can be a powerful tool to align those incentives that Ben talked about. But it's when those things get kind of twisted, when people are doing having one hat over here and then, the same hat, the left hand is doing what the right hand maybe should be doing. That's where you start to get into really dicey territory that you should probably really check with a lawyer about.
Absolutely. Okay, that's all the time we have for questions. This next one is a great one, and we'll do a video with Ann at some point, Self-Fund Health will, and we'll release some more of these questions because they're great questions that we have. This is just a question on how often do you think there are duplicate claims within a fully insured plan? I mean, you could say how many are there duplicate claims on a self-funded plan?
Yeah.
I mean, it happens. So US Beacon that she referenced, right? I mean, she said, was it like 95% of hospital bills have some sort of error in it?
Yeah.
I mean, it's like basically like every single one, right? And the problem is when we don't control the information, when we don't control the data between the hospital and the carrier or whatever it is, wherever there's gray area and things that are unknown to us is power that they have over us, literally. And so
you're in that one horse buggy showing up at a hypercar rally going,
no chance.
They're already at the finish line and I haven't even gotten my horse to start moving yet.
Absolutely. Yes. So, okay, we're going to have a sponsor moment. Thank you so much to Ann.